Thank you. So thank you very much for inviting me. And so my interest is particularly in the inherited neuropathies, and I run a neuropathy clinic, but also a neuromuscular clinic and also the ataxia clinic. So kind of broad neurogenetic interest generally. And I wasn't sure exactly what the kind of audience was going to be. So it's going to be maybe a little basic explanation in neuropathy, just so we're all on the same page. I'm going to focus on the primary inherited neuropathies, talking a bit about genetic testing and the yield of testing, because I'm interested in that particularly, and a little bit about management, because we are now in the era of some treatable genetic diseases. And there are going to be pictures and details about patients. And although they have given consent for teaching purposes, obviously they don't want their data disseminated around the place. So please don't take any pictures of patient details. So in very basic terms, the brain, the spinal cord is the central nervous system, and everything else is the peripheral nervous system. So it's very complex. We've got the afferent sensory neurons, the efferent motor neurons, and the autonomic nervous system. And if you take a nerve and cut it in half, this is what it looks like. So you have bundles of axons, fascicles, and each of these are myelinated and unmyelinated nerve fibers. And in real life, that's what it looks like, probably a sural nerve with multiple fascicles. Each of these is a large myelinated fiber with the little unmyelinated fibers in between. So that's a fairly normal looking nerve. And these are the kind of symptoms that patients with peripheral neuropathy might report, depending on whether it's a predominantly sensory problem, a motor problem, or an autonomic neuropathy. So quite a wide range of symptoms, and a lot of symptoms, of course, are similar to symptoms that might be reported by people with central nervous system problems. So you can very broadly divide peripheral neuropathy into genetic and acquired. And in the genetic group, we've got the primary neuropathies, which include Charcot-Marie-Tooth disease, hereditary sensory and autonomic neuropathy, hereditary motor neuropathy, hereditary neuropathy with liability to pressure palsies, and hereditary neuralgic amyotrophy. And in and around 100 genes are known to cause that bunch of conditions. And then we have about 150 genes that we know can cause neuropathy as part of a more complex neurological phenotype, like the hereditary spastic paraplegias and so on, which often have neuropathy as part of it. But I'm not going to talk about those today. So these are what we're going to focus on. And it used to be thought, and even the classification system follows on from this, that these were very distinct, separate disorders caused by mutations in different genes. But it's really much more of a spectrum. And we now know that a gene that might typically cause a hereditary sensory neuropathy can equally cause motor involvement. And many of the genes that might cause a motor neuropathy might also cause, in fact, spasticity, because they're axonopathies, really. They're not just peripheral nerve problems. And in our clinic in London, which had a big inherited population, when we broke it down by phenotype, the majority is CMT, so motor and sensory involvement, with about 10% making up hereditary motor neuropathy, 11% hereditary sensory neuropathy, and about 8% hereditary neuropathy with liability to pressure palsies. So even though CMT is technically classified as a rare disease, it's not actually that rare. And CMT is probably the most common inherited neurological disorder. It can be inherited in basically any different way: dominant, recessive, X-linked, mitochondrial even can present as typical CMT. And if you look at the prevalence data, so the original prevalence data from CMT was from Norway in, I think, 1979, and that suggested a population prevalence of 1 in 2,500. But more recent studies have suggested that it could be as much as double that, which, if you extrapolate that to the Irish population, would suggest that there should be about somewhere between 2,000 and 4,000 people in Ireland with CMT. Having said that, there was a population-based epidemiological study published a number of years ago, not many years ago, a couple of years ago, and they found a population prevalence of 10.52 per 100,000, which would suggest that there are only 526 people diagnosed with CMT in Ireland. So that suggests that a huge proportion of people are going undiagnosed. And if you look at the other conditions there that have a lot more visibility in the media, motor neuron disease, Huntington's, you see how small the frequency is compared to CMT, but there's really very little visibility for CMT in the media because, you know, I guess in some ways it's not as emotive as some of the other conditions. So in terms of classification, neurophysiology is really important. So what we're looking for when we do neurophysiology is the size of the amplitude and then the velocity. So we do 2 points along a nerve and we measure the velocity along that nerve, and then this is measuring the sensory amplitude and velocity. And then once we've done that, we can classify people with CMT into demyelinating if the motor conduction velocity is less than 38 meters per second, axonal where the velocity is more or less normal, and intermediate, which is somewhere in between. And that is helpful for phenotyping and genotyping. So you'll hear me harp on about clinical phenotyping, but it's really important. So CMT, though, is very heterogeneous. So mutations in a single gene can cause many different phenotypes. So for example, mutations in myelin protein 0 might cause an early onset demyelinating neuropathy, but can also cause an adult onset axonal neuropathy, and also can cause an intermediate neuropathy. And equally, the same phenotype can be caused by mutations in many different genes. So a typical CMT1 phenotype, which is most often caused by the PMP22 duplication, the same phenotype can be caused by mutations in LITAF, myelin protein 0, SH3TC2, and many other genes. And then, even with the same gene, the inheritance pattern can vary. So, for example, GDAP1 mutations can be inherited in a dominant or recessive pattern. So having said that, you might say, well, then phenotyping is pointless because everything can look the same, but that's not the case. There may be very specific phenotypic clues. So for example, if someone has vocal cord involvement, that implicates a very small number of genes. And particularly now, when we do large panels of genetic testing, and you might get a number of different variants, the clinical phenotyping really helps you to separate out what is or is not relevant. So there's a lot of phenotypic variability even within families. So this is the mother in a family with an SBTLC2 mutation. So typically mutations in this gene cause hereditary sensory neuropathy type 1, which typically presents in the teens or 20s with lancinating pain. Then they get a progressive sensory neuropathy, and as a result of the sensory neuropathy, they get ulcerations, mutilations, amputations. But you can see here she's in her 50s. She has a little bit of wasting, not much. She has maybe a few blisters on her toes, but has not had any amputations or terrible mutilations. So she's fairly mildly affected. Whereas this is her daughter, who's about in her 20s, and you can see that she's got very profound weakness and wasting with contractures in the hands and the feet. So again, an atypical phenotype for that gene, because in this case it's much more motor, but you can see the difference in phenotype between the mother and the daughter with the same mutation. So these people all have CMT, and you can see big differences between them, so ranging from kind of mild atrophy in the hands, pes cavus, hammer toes, to very profound weakness, even including facial and bulbar and respiratory involvement requiring wheelchair and non-invasive ventilation. And all of these people have CMT, it's a very heterogeneous disease. And then when we look at the genes, so CMT is named after Charcot-Marie-Tooth, who described it back in the 1800s. There was an attempt to classify inherited neuropathies in the 70s. The first linkage was in 1982. The first gene was discovered, the PMP22 duplication, in 1992. And in the next number of years, you can see maybe like one gene or no genes each year based on kind of functional candidate genes. So they looked at the myelin, looked at the genes that encode myelin, and then sequenced those genes in people with CMT, and they find that some of those genes cause CMT. And then over the next number of years, the Human Genome Project suggested a number of candidate genes, and we found more genes. And then since the advent of whole exome and whole genome sequencing, you can see the rate of discovery of new genes has taken off, and we're discovering 10 new genes a year that might cause CMT. So it just shows, you know, it's still a very rapidly moving field. And this paper, which doesn't feel like 7 years ago, but it's 7 years ago since that's published, shows the location of genes that are implicated in CMT. So, you know, there are many more discovered since then, but, you know, from the Schwann cell, the myelin, channels, axonal transport, synaptic transmission, toxins, mitochondria, anything to do with a peripheral nerve or a Schwann cell can basically cause CMT. So when I see someone in the clinic with neuropathy, there are some clues towards someone having an inherited neuropathy. Obviously, if there's a family history, but a lot of people with CMT do not have a diagnosis. And so often people come in, they say, no, there's no family history. And it's only when you ask about, you know, does anyone in your family have funny feet, or wear calipers or splints, or, you know, use walking sticks or walking aids later in life, that it becomes clear that there is in fact a family history. Typically, there is a long history going back often to the first decade with delayed milestones. Very often poor at running in childhood. They're always the people who are at the back of the race. And importantly with CMT, typically patients do not report sensory symptoms, even though they do have a lot of sensory involvement. And then on examination, things like foot deformity, scoliosis, hip dysplasia are very common. Tonic pupils, deafness, the weakness and the sensory loss is typically symmetric and length dependent. And with CMT, vibration is typically more affected than PIN, whereas with hereditary sensory neuropathy, PIN is more affected than vibration. So all of these things are clues, but they are not absolutes, and there are many exceptions. So some neuropathies, some inherited neuropathies can present very acutely. Conduction block, which used to be thought of as something that was kind of pathognomonic almost of an immune-mediated neuropathy, has been described now many times in CMT. And many genes have been reported to cause a phenotype that may range from CMT to hereditary spastic paraplegia. So these are really axonopathies rather than peripheral nerve disorders. So this is the story of what I'd call typical CMT. So he was referred at the age of 40 by orthopedics, but up to that point had never seen a neurologist. He was always ungainly in primary school. He could never run fast or play sports. He would often turn on his right ankle. And at 17, he was referred to orthopedics and had a fusion procedure for his foot. Things slowly progressed. He would fall regularly, and he started wearing an ankle-foot orthosis, which is a splint, basically, of the ankle. At 39, he fractured his right ankle, and that's what led to him being seen again by orthopedics, and they referred on to see, was there a neurological problem? So in terms of his symptoms, he didn't really go with any symptoms, you know, it just happened to be referred. He denied numbness. He didn't really complain much of weakness, but he said his balance was poor. And he was unemployed because he worked on building sites, but found when he wore heavy boots, it was just too difficult to drive the machinery. And again, told us there was no family history, but when we went into it, it was clear that probably his father and grandfather were both affected. So this is him. So you can see he's got pretty good musculature above the mid-calf, but then there's distal wasting. He's got high arches, hammer toes, and you can see he's inclined to stand on the outer aspect of the feet, which is very common. So he's unable to stand on his heels. There was minor weakness in the intrinsic hand muscles and ankle dorsiflexion. Reflexes were diminished. Pin was reduced to the ankle and vibration reduced to the knee. So very typical sort of phenotype. And the CMT neuropathy score, which is a scale we use to determine severity, was 13, suggesting moderate severity. So we went on to have neurophysiology, and the things in red are the abnormal. So you can see that the velocities are uniformly slowed, F waves are prolonged, distal motor latencies are prolonged. So he's got a uniform demyelinating neuropathy. And if you remember, he had no sensory complaints and minor enough sensory findings on examination, but none of his sensory responses were recordable. So that's fairly typical. So he had autosomal dominant CMT1, and genetics confirmed that he had the PMP22 duplication, which is the most common form of CMT. So CMT1A, It's autosomal dominant. His phenotype is the kind of typical, although it can be variable severity, and I do have 1 or 2 patients in wheelchairs with CMT1A. Typically, you can get the symptoms back to the first decade. Hip dysplasia is very common, and CMT1A accounts for about 50% of all CMT and 70 to 80% of CMT1. And it's a dosage problem. So it's caused by duplication of PMP22 on chromosome 17, and it's thought that that happens by unequal recombination during meiosis. And the interesting thing about it is, so during this process, you end up with either a PMP22 duplication or a PMP22 deletion. And then depending on which of these goes on to produce the child, you have CMT1A or HMPP. So they're the exact opposite genetically. So these are the feet of some people with CMT1A. You can see there's wide variability. This man here can't stand on his heels at all. He's had a lot of surgeries, and he can only stand and walk when he has on his splints and his boots. So that's quite disabling. You know, if you imagine he gets up at night to go to the toilet, he can't unless he puts on all of his gear. And although I said it was symmetric, you know, you can have quite asymmetric feet. And you see this person, his foot is rotating, and that leads to a lot of ankle instability and often fractures. And there's a normal nerve again, and there's a CMT1A nerve. And so you can see there's axonal loss, and there are these onion bulbs, which are caused by de- and remyelination happening. And just for comparison, this is the nerve of someone with HMPP. These are historic slides because we would never biopsy someone now with these conditions, but you can see that the density of axons is not bad, but you see these abnormally thickened myelin, they're called temaculae. This is a single axon that's been teased out, and you can see the temaculus of thick myelin, and that makes the nerves very vulnerable to pressure, and so at pressure points they get compression neuropathies. And the most common being the perineal at the knee, so people who are habitual knee crossers will get a foot drop on the knee that they're crossing as the most common presentation of that condition. And if you remember, I said that HMPP and CMT1A are genetically the exact opposite, so they should, in theory, occur at relatively the same frequency, but in our clinic in London at least, the frequency of HMPP was only 8% compared to 71% of CMT, half of which would be CMT1A. So that's because a lot of people with HMPP probably are not diagnosed. So the second most common cause of CMT is CMT1X, X-linked, caused by mutations in the gap junction beta-1 gene. And this encodes connexin 32, which is important for forming these gap junctions between cells to allow radial transfer of potassium and other molecules through the layers of myelin into the axon. And this is a fairly typical family. So this boy, onset at 8, and by the age of 24 has very profoundly weak dorsiflexion, whereas his aunt, onset in her 20s and at 48 has mildly weak ankle dorsiflexion. So that kind of phenotypic difference between the males and females is a good clue to this condition. This is a mother and son from that family. So now actually the mother is fairly severely affected for a female. So you can see she's got quite a lot of wasting and weakness in the hands and feet. But the son, who's only 18 or 19 here, is obviously significantly more affected. And typically males have a relatively uniform phenotype of moderate to severe disease, whereas when we looked at a large cohort of women with CMT1X, we found that a third were as severe as men, 2/3 were in the mild range, and then a couple of patients were essentially asymptomatic. And they typically have an intermediate velocity. The other thing about this is it's quite interesting because they're quite patchy. So typically the median nerve is much more affected than the ulnar nerve, neurophysiologically and clinically. And even though this is considered a peripheral nerve problem, connexin 32 is expressed centrally. And this is the scan of one of my patients with CMT1X who has had a single central kind of episode of a hemiparesis. And you can see that her scan shows multiple inflammatory demyelinating type lesions, which in another context you might think could be MS, for example. So this is someone with a more severe phenotype. So just listen to his voice first, if it works. No, okay. Anyway, he's got vocal cord involvement, which is why I was saying to listen to his voice. So you can see that he's got bilateral foot drop. He walks the high stepping gait. You can hear a very characteristic slap when he walks. You can see that he's got clear wasting and weakness in the arms as well. So you can see there the degree of even proximal weakness. This video was taken a couple of years ago. Mostly he uses a wheelchair now. And you can see that he has to hyperextend his knees to walk. He's also got a bit of a tremor, which is not uncommon in CMT. And he has recessive CMT2 due to homozygous GDAP1 mutations. So moving on to a slightly different phenotype, this is congenital insensitivity to pain, which is classified under the hereditary sensory neuropathies. So this lady has an interesting history. In her childhood, in infancy, she used to bite, as soon as she got teeth, she used to bite her gums. She used to bite the sides of her cot and had terrible injuries, and actually all of her teeth were removed as a small child. One time she fell out of her cot and fractured her hip, but it was not realised because she didn't have any pain. So there was a long delay before the diagnosis, and she developed osteomyelitis of the hip and ended up having a girdle stone procedure, which is where they essentially remove bits of your hip. She's developed a Charcot joint over time from repeated injuries. And there was one occasion where she wanted to see whether the iron was hot. She put a hand on the iron and she didn't realise that her hand was burning until someone, I think, smelt burning, or maybe she heard sizzling or something, and she got a very bad burn to her hand. Interestingly, she does not have any weakness or sensory loss, so she can differentiate between sharp and dull and hot and cold when you touch her, but she does not feel any of these things as being painful. So when we did QSTs, which are quantitative sensory testing, so this is where we put an electrode on the hand and the foot, it gradually heats up or gradually cools down, and you have to say, first of all, when you feel that you can tell that it's hot or cold, and secondly, you tell them when it feels painful. So she was able to reliably say that's hot or that's cold, but she did not feel it to be painful, and the machine would just cut out at the threshold. And she had complete anosmia, which her mother confirmed she'd always had. She was never able to tell what was cooking. And she had recessive mutations in the sodium channel 9A, which is expressed in dorsal root ganglia and the olfactory bulb. And that's a fairly typical phenotype for that. And even though she knows she has this condition, it's very difficult for her in practice. There was one time she stepped off a high step, she heard a bit of a crunch. She felt okay, she kept on walking, but she knew she'd probably done something, and she went to the emergency department and asked for an x-ray, and she was told that there was no need for an x-ray because she was walking and she didn't have pain. And she explained that, well, I have this condition, but she was sent on her way without an x-ray, and she subsequently rang and said, I think I need an x-ray. And I brought her in, and she'd fractured her hip and had a hip replacement as a result. So this illustrates how important pain is as a symptom. It is really a very important protective reflex, and it's fairly devastating if you lose that response. The other thing is that it gives us important targets for drugs. So if you were able to target that channel, that would be a very effective painkiller probably. So, you know, we learn a lot of things from these conditions. This is another family I have with recessive congenital insensitivity to pain, slightly different phenotype. So 5 affected siblings, and the mother always knew as soon as they turned about 4 or 5 months old if they were affected or not, because as soon as they were able to turn onto their tummies, they would start rubbing their faces on the carpet and get these carpet burns on their face, and then they would pick and scratch. And she tried all sorts of solutions, in the end developing a sort of homemade straitjacket to keep their elbows straight so they weren't able to scratch until they were old enough to realise that they shouldn't do it to injure themselves. They've also had other injuries played on in games with fractured hands and things like that. They also have impaired QSTs, so they just max out the maximum and the minimum without feeling pain, although they do not have completely preserved perception of hot and cold on testing, whereas the other lady did. But very similar, and this is due to this transcriptional regulator, PRDM12. And another sensory phenotype, this is hereditary sensory neuropathy type 1, which is the most common form of HSN. Again, it's a dominant condition. This is the one that presents typically in the teens or 20s with lancinating pains and then a progressive sensory neuropathy. And as a result of the neuropathy, they develop ulcerations, amputations, and complications of a sensory neuropathy. So you can see this lady's had a couple of toes amputated, and you see these toes, the ends of them have been damaged by repeated trauma. She's got maybe an ulcer or two, and she's a below knee amputation on the other side from, you know, probably osteomyelitis or something. This person's had a knee replacement because of repeated injuries, and this man bought a takeaway coffee cup, a takeaway coffee, but forgot to put on the protective cardboard sleeve and wasn't able to feel that it was hot and got those burns from that. And this is an interesting condition because it's due to a mutation in an enzyme, and most conditions resulting from enzyme problems are due to lack of the enzyme, so they're recessive. But this is due to a mutation in the enzyme that's involved in substrate specificity. So the enzyme serine palmitoyl transferase is involved in the condensation of palmitoyl-CoA with serine, and that drives down this reaction that forms sphingolipids. But if you have a mutation, the enzyme preferentially wants to use alanine or glycine instead of serine, and then it still forms sphingolipids, but you also get these deoxysphingoid bases. So in patients, they still have normal enough levels of sphingosine bases, but they have elevated levels of the deoxysphingoid bases. And these have been shown in vitro to be toxic to sensory neurons. And I'll mention that there is possibly treatment coming for that. This is another sensory neuropathy, this time with more autonomic involvement, and sometimes in some of these conditions, intellectual disability, which makes it much more difficult to manage if the patient does not understand that they are at risk of injuries. So in terms of the chance of getting a genetic diagnosis, it depends on the phenotype. And this is why the clinical assessment and the phenotyping is important. I already said that about half of all CMT is CMT1A, and 70 to 80% of CMT1 is CMT1A. And we looked at a large number of people with inherited neuropathy attending the clinic, this is from London, and found that of the patients that got a genetic diagnosis, 92% of those were just from the most common 4 genes. So the majority PMP22 duplication, GJB1 making up about 10%, myelin protein 0, mitofusin 2, smallish percentages, and everything else really less than 1% each. And the phenotypes generally correspond to what we know. So the PMP22 duplication only causes demyelinating CMT, mitofusin 2 only causes axonal CMT, and GJB1 typically causes intermediate. But what this paper also looked at was the rate of diagnosis if you attended a specialist clinic versus just, if you attended a general neurologist. And it highlights the importance of phenotyping. So in the clinic where we'd clinically assessed them, phenotyped them, the genetic diagnosis rate overall was 62.6%, very high rate of over 80% if you had CMT1. Whereas in the patients where the neurologist had sent us the samples and just said, oh, please test PNP22, or this person has CMT, the genetic diagnosis rate is less than 40%. So it just highlights the importance of phenotyping, really, and attending a specialist clinic. So that study, of course, was done in the days of sequential individual Sanger sequencing, and now we have gene panels available. This allows screening of multiple genes quickly, and that's much more cost effective for diseases like CMT, where there are many different genes to look at. But there are, it is possible to miss mutations if coverage isn't complete. Panels do not typically pick up duplications or deletions, and you may pick up variants in non-relevant genes, and that's why the clinical phenotyping is so important. These are the panels that I typically use, but there are many others. And if you look at the diagnosis rate, it's fairly similar. So this is our results from Sanger sequencing individual genes, and this is a more recent study looking at a gene panel. So the overall diagnosis rate is similar, 58%, and we had 62% or whatever. So very similar, but much quicker. And we also now are able to do whole exome and whole genome sequencing, which is cost effective. Actually, the whole commercial whole exome is only a couple of €100 more than the Bristol panel, for example. It's much quicker, and other studies in other neurological disorders have shown that it abbreviates diagnostic odyssey by about 5 years, probably. But there are a few things. Of course, the depth of coverage is important, and the importance of appropriate counselling pre-testing, because about 5% of patients have incidental findings like cancer mutations and so on. And then we often find polymorphisms or variants of uncertain significance, which require a lot more work before we can say if they're relevant or not. So the use of whole exome in neuropathies, there are only small numbers done, but an overall diagnosis rate of about a third. And this is in my clinic. So 30% who've had a whole exome or whole genome have a definite pathogenic mutation that explains the phenotype, and another 27% have a variant which might or might not be relevant and needs further work. So just in clinical practice, these are some incidental findings which I've had in the last year or so. So one patient with a genetic diagnosis of glucose 6-phosphate deficiency, dehydrogenase deficiency, which obviously was incidental to his neurological problem. Another lady who had a PMS2 mutation, which causes a dominant cancer syndrome. So she has recently had a prophylactic hysterectomy and is now on a cycle of cancer screening. And another patient with a KCNQ1 variant, which causes lung QT syndrome, which causes sudden adult death. And one case of non-paternity. And interestingly enough, in all 4 of these patients, we did not find a pathogenic mutation that explained their neurological problem. So obviously there are lots of benefits of genetic testing. It prevents further unnecessary investigations. It may identify patients who are suitable for clinical trials. Vincristine causes a very severe idiosyncratic drug reaction in people that have CMT1A, so you would never give vincristine without doing neurophysiology first. It guides prognosis to some extent, although of course for many of the more recently described genes we don't have a lot of data on natural history, and pre-implantation genetic diagnosis and risk of recurrence to children is important. I also think you can't really put a price on having a diagnosis. So, I mean, a lot of patients have a clinical diagnosis, but they don't really feel they know what they have until you tell them their genetic mutation, and that I think is very helpful for people. And we are now in the era of genetic therapies, so it's very important that we know someone's genotype, obviously, before knowing whether they can benefit from a treatment. So this is just, about the phenotype business. This patient was referred to me, known to have HMPP due to the PMP22 deletion. He was just referred for ongoing follow-up because I have an interest in it. And this is him and his family. All of the family swore that neither of the parents were affected. I've seen the mother and she isn't, but his father died at 28 in an accident. What the accident was, in fact, was that he tripped into the path of an oncoming car. So I don't know, maybe he had a foot drop. So his history was that he walked at 2, which is delayed. He had foot surgery at 8, slowly progressive walking difficulty and hand symptoms from the early teens, and he was diagnosed with CMT at 14. By 15, he had such profound weakness in his hands that he had to have a tendon transfer to give him a pinch. So that implies that he had very severe weakness. And now in his 40s, he walks with a stick or pushing a buggy. He's a lot of difficulties with bottle top, zips, buttons since his 20s, and very little in the way of sensory symptoms. And he's never had a mononeuropathy. And on examination, I'll show you a picture of him, but he's got a lot of wasting, very weak in the arms and the legs, areflexic, little in the way of sensory findings, and a moderate to severe phenotype. So you can see he's got wasting really from above the knee. He's got a lot of wasting and weakness in the hands, and wasting really up to the elbows. So this is not the phenotype of HMPP. We assessed his other family members. So all of the other family members have a more typical HMPP phenotype. So his sister was normal in childhood. She did a charity cycle in her 20s and developed bilateral hand numbness, which lasted for a few weeks and then resolved. And intermittently, when she writes, she gets tingling in the ulnar distribution. So that's a very classic story for HMPP. And the two of the children in the next generation, so this symptom of numb hands in the morning, which you shake out, is typical for carpal tunnel syndrome, and tingling in the ulnar distribution if he leans on the elbows, and tingling in the foot if he crosses the legs. And the other one has tingling in the hands when he cycles. So these are typical HMPP stories, very different from the proband. Whoops. And the neurophysiology shows just that this is the proband. So all of his motor responses are absent in the upper and lower limbs, whereas all of the rest of them just have typical HMPP type findings like carpal tunnel, slowing of the ulnar nerve around the elbow, slowing of the peroneal nerve at the knee. And the sensory studies show mild slowing in all of the family. So the electrics of all of them except him are fairly typical for HMPP, and he's very atypical. So first of all, we just double checked the report, and yeah, it looked like he had the PMP22 deletion, and we checked the affected family members and they all had the deletion as well. So is that it? Does he just have an atypical phenotype of a common disease? Well, I didn't think so. So we repeated the PMP22 deletion just to be sure, and that was positive. We did the panel, that came back negative, and then we went on to do whole genome sequencing, which confirmed the deletion, but also showed 2 sigma-1 variants. Now, they're both novel, which is often a problem with the genetic testing. You find something novel and then you don't know, but they are, the in silico parameters look suggestive. They're not seen at any frequency in any of the databases. And we did segregation analysis, which confirmed that he's compound heterozygous, and the rest of the family are either don't carry them or are heterozygous. So this sigma-1 mutations typically cause a juvenile onset distal SMA phenotype. So his phenotype would certainly fit with this, but it needs a little more work to absolutely confirm, but I think this is why his phenotype is different. So it just highlights the importance of phenotyping. But having said that, just because a patient has a variant doesn't mean it's causative, and each of us have at least probably 70 de novo variants, which neither of our parents have, which could be pathogenic. So in terms of quality of life, not a whole lot of work has been done on this, but there is a discrepancy certainly between the way that patients experience the condition and the way doctors perceive it. And these studies have suggested that patients with CMT have the same emotional stress levels as patients with disabling stroke. and over a third would choose not to have similarly affected children. So definitely has a significant impact on quality of life and deserves more resources, really. In terms of management, at the moment there is no specific management or specific treatment. The problem with treatment is that it's likely to be gene specific. Ideally, you would give the treatment before disability occurs, perhaps pre-symptomatically, which means that because these are conditions which generally don't affect lifespan, it's going to have to be safe in children and safe to be taken for decades and presumably affordable. And part of the problem with CMT is that it's very slowly progressive, which makes change from year to year difficult to measure. And for the purposes of trials, which generally only are done over 1 to 2 years, it's very difficult to detect enough change in a treatment group versus a control group to be able to prove that something is beneficial. And the outcome measures that we have are relatively insensitive to small changes. The other thing is that the phenotype's heterogeneous, and it's difficult to predict severity. So, you know, whether one person might not necessarily warrant treatment, and whereas another one might. And this highlights really the need for biomarkers. So the outcome measures, we do have the CMT-NS score, which is certainly easy to perform. It's reproducible, it's reliable, inter-rater and intra-rater, and it's relatively clinically relevant, but it is not sensitive enough to small changes over short intervals. And this is a big issue, and there's a lot of interest now in biomarkers, a lot of money available. There have been some studies looking at neurofilament light chain. MRI muscle looks promising as a biomarker, but of course, you know, is not readily available or easy to do. And skin RNA transcripts also look potentially useful, but again are invasive and would need to be repeated, so not an ideal biomarker. And there were a number of different studies looking at vitamin C and CMT1A, because vitamin C in vitro affects the regulation of PMP22 expression. And the mouse model, there was only an initial mouse model study which looked like it affected the phenotype, and because vitamin C is very readily available and cheap, the treatment trials were kind of expedited. But partly perhaps because of the lack of a sensitive enough outcome measure, none of those trials showed a significant effect on outcome. But this treatment is more promising. So I talked about HSN1, the enzyme problem, and we know that if you load a person with serine that has this condition, you can drive the reaction back towards the normal reaction with serine. And we know in vitro that that does reduce the deoxysphingosine base levels in patients. There has been one trial, but it was only in 18 patients. And it certainly was well tolerated and showed a reduction in the level of the deoxysphingosine bases, but the trial was done over less than a year, so it was, and there's no good outcome measure at the moment for HSN1, so further trials are planned, but that is certainly a promising treatment for that condition, even though it's a rare condition. And a number of other treatments have sort of come and gone over the years, nothing terribly hopeful that I know about right at this minute. So really at the moment it's basically supportive management, but that is very important. There's lots of different types of splints. Patients have individual preferences depending on comfort and their level of activity. Physiotherapy, occupational therapy, regular stretching to prevent tightening and contractures. And there is a suggestion that strengthening the more proximal hip flexors does benefit your walking ability if you have distal weakness. In terms of orthopedic management, a lot of people with CMT, adults, older adults, have had a lot of surgery on the feet in childhood. And it's a paper back in 2006 suggested that almost 80% of children with bilateral cavaverous feet had CMT. So nowadays, the orthopedics, I think, are much more in tune with that, and when patients are referred to them, as they inevitably are referred to orthopedics for some reason more than neurologists, the orthopedics refer them on rather than just going and fixing the position of the foot. So that is good. And in general, I advise patients to avoid surgery if at all possible, unless there's significant pain, perhaps due to the position or inability to find footwear that really fits. Soft tissue procedures can be useful though. Achilles tendon lengthening and giving tendon transfers to give a pinch can be very functionally useful. So it's not a no to surgery altogether, but I'm not keen on the fusion procedures that they used to do. So just to finish up, CMT is a very heterogeneous group of diseases. It's definitely under-recognised and underdiagnosed, and careful clinical phenotyping is very important for diagnosis, guiding genetic testing and interpreting results of genetics. And at the moment, unfortunately, it's just supportive management, but there are lots of, I think, exciting things to come in the future. And I'd like to remind you all that it's Rare Disease Day tomorrow. And if anyone's interested in the clinics, they're on the Tallaght Hospital website. Thanks.
Thanks, Sinead. That was an excellent talk. Hugely informative, especially for me who doesn't deal with patients day to day. I'd like to open up to the room for questions, and I think we can take questions to people who are online as well. I'm not sure how that will happen, but I got a WhatsApp during the thing to say that we could. We'll see if that happens. So does anyone in the room have any questions? Yeah.
Did you say that men that are diagnosed with Charcot-Marie-Tooth are more severely affected than women or girls?
For CMT1X. So for the X-linked type, typically the men are more severe and earlier onset than women. But for, other types, it's more or less the same. Perhaps with the sensory type, there's a suggestion, but, not more than that.
Any other questions in the room? I have a question.
Yeah.
You talked about the heterogeneity of the disorder, and that was quite varied even with the same mutation. And then you showed that case there where the
mother and daughter.
The mother and daughter were quite different, but also that turned out in one case where I think it was the MP2 deletion, and you had the sigma.
Oh yeah.
So, how much of this variability do you think is due to the coexistence of other genetic factors, or is it environmental factors, or could there just be the developmental pathway as just it's a stochastic chance process?
Yeah, so I think we don't really know that, and certainly in some cases there are definitely other genetic factors, and they have another, like in that family, I'm quite sure that the sigma-1 explains why he has this very motor early onset phenotype, which is nothing like HNPP should be. But in CMT1A, which is the most common type of CMT, you do see a lot of variability. And there is work into that, looking at are there other genetic modifiers. But I'm not sure that anything definite has really come out of that. But presumably, yes, there are, I would guess. But what those are and whether it's possible to, allow for that with treatments and stuff is, not known.
Yeah, but maybe not at this time.
No.
But, anyone else have questions, or is this the moment to say we should go for tea and biscuits? So thank you all for coming, and thank you especially for coming, Sinead.
Welcome.
Wonderful. So thanks to everyone online. We will be organising another talk, so information will be going out on that. We haven't confirmed just yet. But if any of you are interested, we're hopefully going to have a Charcot-Marie-Tooth family day, kind of a disease awareness day. So if anyone is interested in that, we have a sign-in sheet outside that you can put in down your email address. We'd like to talk at Ulysses Neuroscience. We'd like to talk to you. We'd like to talk to clinicians. We want to talk to everybody because we are trying our best to research and to disorders like this and to hopefully come up with things. We're particularly interested in biomarkers, but without biomarkers, there's not much we can do in terms of, you can see how difficult it is to classify and to identify treatments and to even know what to treat without knowing a good biomarker. So thanks everybody, and as I said, tea and coffee outside. So
Great.